Thank you for the introduction, and thank you for joining APCIS to explore cardiac care together. Initially, I had a plan to focus on restrictive cardiomyopathy. However, I will cover that in a later demonstration. For now, I'd like to share cases of burnout in HCMP patients, like phenotype of restrictive cardiomyopathy. I'd like to introduce a case of a 39-year-old female patient with septal hypertrophic cardiomyopathy. The patient underwent a subaortic septal myectomy at the age of 13. Following the surgery, she developed severe aortic regurgitation between NCC and RCC. This patient also underwent an aortic root extension and aortic valve replacement due to aortic valve regurgitation at the age of 19. Since then, she has experienced recurrent atrial fibrillation, atrial flutter, which required DC cardioversion. And additionally, she developed amiodarone-induced thyroiditis as a complication of her treatment. During this time, the patient got married and had a child. During her C-section delivery, she experienced another episode of atrial fibrillation and rapid ventricular response. So she needed to C-section delivery. And after following this, she underwent radiofrequent catheter ablation to manage her recurrent atrial fibrillation. And after that, she got intermittent dyspnea, and you see her LA is huge, and RA is also huge. But at that time, proBNP was elevated, and ejection fraction decreased up to 45%. And she admitted recurrent hospitalization and cardioversion because of the atrial fibrillation. And afterward, she continued to experience persistent shortness of breath over time. The function of both ventricles gradually decreased. This progress has further complicated her clinical course and required ongoing management. So at that time, I said to her family, and she needs a transplantation someday. And interestingly, there were no other family members with this condition similar to her, except her son. And her father was diagnosed with dilated cardiomyopathy, and she has a mutation of myosin heavy chain 7. And this family history provides some context, but also raises questions about the genetic and environmental factors in her case. And she presented to the emergency room with severe shortness of breath and profound general weakness. Although her blood pressure was within the normal range, her perfusion was inadequate. Based on this assessment, I recommended ECMO and support to stabilize her condition. And I found her lactate level was elevated up to 8. And this finding further supports the need for ECMO to improve her perfusion and stabilize her condition, and also gradually increase her liver enzyme. So we tried to insert ECMO. Before ECMO, I did echocardiography, and echocardiography shows severe airway dysfunction and both atrial enlargement, as you can see. And after we insert ECMO, we found the LFT was elevated up to 2,000. And it means even though her blood pressure was normal, her perfusion level was very decreased, and it means multi-organ failure. And see, her abdomen, the intestine was ileus. It's because of the perfusion decrease. However, the blood pressure was normal, but don't forget, even though the blood pressure was normal, despite inadequate perfusion, her blood pressure remained stable. Under ECMO management, the patient gradually showed signs of improvement, and with her condition becoming more stable over time. And after waiting 14 days with ECMO, we did transplantation. However, due to her condition, she initially experienced primary graft failure, and ECMO support was reinitiated. And however, after 2 days later, we successfully weaned her ECMO off. However, I cannot understand why her RV was dilated and it is remained dilated and dysfunction, and also PA systolic pressure still increased. So we did a CT scan. A CT scan revealed stenosis around the pulmonary artery is kind of iatrogenic, plus aortic valve, near the aortic valve there is a web. It's because of the congenital. So it pressed the pulmonary artery. It causes pulmonary hypertension and obstruction. So we tried to do another surgery, pulmonary artery angioplasty, and ascending aorta replacement after transplantation. And after that, her RV was normalized, and also pulmonary hypertension was normal, and now she is relieved with heart failure, and now she is okay. Then from now on, let's see the biopsy. And Professor Sir?
This is very complicated case. A relatively young patient with advanced heart failure due to hypertrophic cardiomyopathy. This is the resected heart specimen for transplantation. As you can see, so there is a cardiomegaly, and also we have a history of subaortic septal myectomy and radiofrequency ablation for atrial fibrillation and aortic valve replacements for surgery. So we will show everything in this heart. Before we show this case, I'd like to show the sample case of classical hypertrophic cardiomyopathy, that the wall is tremendously thickened, and there is this is a septal and free wall of left ventricle. There is a fibrous scar in septal area, and if you look at to the subaortic part, the protrusion to the subaortic part, and also anterior movement of anterior leaflet of mitral valve produce significant subaortic stenosis, and clearly we can see a scar here. So this part is removed by surgical myectomy in previous history. So we will see what is in this heart and this advanced stage of heart failure. If you examine, simply we just show thickening of some not very different from dilated cardiomyopathy. But if you look at closely, we will clearly see the scar of endocardium in the subseptal myectomy area, and also we can see aortic valve replacement, and also we can as we have seen in the echo, there is a supra-aortic valve aortic narrowing to protrusion, probably due to post-operative scar. And also, if you examine, I'm really worked hard to looking for any remaining evidence for hypertrophic cardiomyopathy even after myectomy specimen. So here you can see several scars, like here. This is a right ventricular wall and septal wall, anterior wall, and this part is removed, but not this level. So the removed part of left ventricle is just the subaortic part here. So below that area, there is still some remaining septal stellate myocardial scar, and I'll show shortly by histology of this area. And also in left atrium, we can see radiofrequency ablation scar. There's not very different from scar in the skin, but it's left atrial wall has a linear scar due to radiofrequency ablation for atrial fibrillation. Let's go to PowerPoint slide, please. Yeah, this is the picture we have seen On the right side, we can see subaortic scar due to surgical myectomy. Next slide, please. This is the scar I have shown in the remaining septal myocardial scar. So on the endocardium, there is a postoperative scar, and below that, the star-shaped area is a stellate scar due to hypertrophic cardiomyopathy. In addition, the intramyocardial coronary artery has significant thickening of the wall, which is very classical for hypertrophic cardiomyopathy. And we usually think myocardial disarray as a hallmark of the histology, but it's a kind of controversial it's not very reproducible. So this kind of stellate scar and coronary artery change and the macroscopic hypertrophy is very important. Next slide, please. Yeah, this is the atrial scar for atrial fibrillation. Thank you.
And I will move to the second case. The second patient is a 55-year-old woman who presented with shortness of breath. She has a significant cardiomegaly. And do you think it's GCMP or DCMP? She had her echocardiography revealed severe biventricular failure along with pulmonary hypertension. And as you can see, both EGA enlargement and also LV dilated and thinning. And coronary angiography shows normal coronary arteries, ruling out ischemic cause of her condition. She was intolerant to heart failure medication. And even though the heart failure medication, her heart function does not recover. And after we reached heart transplantation, we did the vitamin, and because of the RV failure, she needs millinone for RV support. And her LV function was gradually decreased. And very interesting thing is, her family is notably, as most of her relatives has experienced sudden cardiac death. And genetic test revealed that she has a troponin T mutation. And very interestingly, her son carried the same phenotype, same genotype, and has echocardiography finding consistent with the hypertrophic cardiomyopathy, and septum was increased. And he has the similar and same genetic variants. And her daughter also carried some genetic mutation. She experienced a sudden cardiac arrest, which is necessary to implant of ICD. Echo shows findings consistent with hypertrophic cardiomyopathy. So I thought she's HCMP and failing heart. And from now on, let's see her pathology.
Yeah. Next slide, please. Yeah. This is the sorry. Yeah. This is a specimen after transplantation. So if you cut from the short axis, we can see very not unusual for dilated cardiomyopathy, but we have a genetic history of this case. And also, if you look at carefully, we can see unusual stellate scar in the anterior septal area of this zone, which may represent as a hypertrophic cardiomyopathy scar. So this is not very much protruding to outflow part of this ventricle at this stage, but in the previous time, there will be more hypertrophied and advanced hypertrophic cardiomyopathy in this case. So we cut in long axis section to make prove this is hypertrophic cardiomyopathy. This is aortic valve, coronary arteries, and mitral valve, and is here. And if you cut this area, there we can see vaguely some scars on a little below this aortic valve area. So we are going to show it in microscope. PowerPoint back, please. PowerPoint, please. Next slide, please. Yeah, this is histology. So because of the heart failure, the myocardium is dilated and wall became thinner, but still there are scars of hypertrophic cardiomyopathy at the subaortic part. So total thickness of the wall decreased after failure, but still the remaining scars is there in the subaortic part of ventricular septum in this particular case. Thank you.
And more.
Thank you.
Okay. So in summary, this case is underscored the significant impact of family history, and hypertrophic cardiomyopathy can progress to burnout phase, leading to presentation that mimic DCMP or restrictive cardiomyopathy. So early identification through genetic screening can guide clinical decision and potentially improve outcomes. Thank you for your attention.